Assalamu alaikum, everybody. Viewers, we have a panel of anesthetists and also physicians from other specialties to discuss the COVID-19 and how to ventilate a patient suffering from COVID-19, an area where we make a lot of difference because people who end up in ICU, they are the ones who contribute to the fatality of the disease. So we want to discuss the considerations which are important for ventilating a COVID-19 patient. Today I have with me Dr. Mamoon Yusuf from Qatar. Welcome, Dr. Mamoon Yusuf. Please try and introduce yourself in maybe 15 seconds to the audience. Dr. Mamoon Yusuf, please.
Hi, assalamu alaikum everyone. I'm Mamoon Yusuf. I'm working as a consultant in medical intensive care unit in Hamad General Hospital in Doha, Qatar. Previously, I was working as a consultant in Manchester Intensive Hospital, and I'm very pleased to join you all together for discussion.
We welcome you here. We have Dr. Irfan Rashid. Dr. Irfan Rashid, would you please introduce yourself to the panel?
Yeah, I'm Irfan. I'm working as a GP and a pediatrician in West Yorkshire. I'm also coordinating this webinar, and most of viewers will know, and they have sent me questions already.
Thank you. We have Dr. Rana Hafizur Rahman, a very experienced consultant anesthetist. Please, Dr. Hafizur, can you introduce yourself?
Sure. I'm, as mentioned, Dr. Rana Hafizur Rahman. I am from Tameside Hospital in Manchester, and working as a consultant in anesthesia and intensive care. And I'm obliged for APPS2 and Medical City to organize this webinar. So we did hold a webinar last week as well, so we had some questions left over. We will hopefully try to address them.
Thank you. And we have Dr. Tamur Mirza, the ex-president of APPS UK, consultant anesthetist. Please introduce yourself, Dr. Tamur Mirza.
My name is Tamur Mirza, as Suhail has already mentioned. I'm working as a consultant in anesthetist and intensive care medicine at one of the hospitals in Manchester. We did this webinar last Sunday, as Suhail said, so a few questions were left over. We're trying to answer those. Thank you.
I appreciate everyone's input and time today. This webinar is hosted by me. I'm Dr. Suhail Chukta. I'm orthopedic surgeon and Microsoft specialist consultant in telehealth. My interest in orthopedics and technology, especially telehealth technology, is parallel, and I'm hosting this at the platform of Medical City Online today. So we start with the questions which were left over from last time, and then we can rotate turns to answer more questions. There was a question asked about question from Pakistan from Anood Ijaz, Dr. Anood Ijaz. His question was, what is the factor which differentiates between those who are going to recover and those who are not going to recover? And that question, can I ask Dr. Tamur Mirza to start on this one, please? Dr. Tamur Mirza.
Thank you very much. There is a bit of a controversy. It's a good question, actually. There's a bit of a controversy here that when the patient is being intubated and when not. I gather and presume that this question is addressed towards the intubated level 3 patient, which is already on the ventilator. So we take it as when the patient was intubated, whether it was during the early stages of respiratory failure or during the late stages of respiratory failure. So one is if the patient was intubated during the early phase of respiratory failure, the chances are good. Similarly, the younger the patient is, and with less or no comorbidities like hypertension, like diabetes, and one of the other comorbidity is obesity. If the patient is not obese and not have these comorbidities, then the chances of recovery are good. At present, the mortality rate, as indicated by one of the London panels, is about 50% in intensive care patients who are intubated and ventilated.
And Dr. Fizur Rahman, I want to bring you in on the same question. What role do you assign to be for those who got COPD and who smoke? Do they have a higher mortality?
I mean, the figures so far suggest that obviously patients with comorbidities, they have higher mortality, and overall, we're not really just saying what happened in the intensive care, but as far as our experience is concerned, we kind of maybe learned from Spanish and Italian experience, and we started kind of really triaging early, and it's possible that we may be sort of triaging them early enough and maybe selecting our patients carefully. So patients who have comorbidities, they are sometimes sort of not considered for ventilation. So it's possible that obviously learning from others' experience, we have changed our pattern. So it's a possibility that may affect our results. But yes, on balance, patients with comorbidities in general in intensive care normally have got higher mortality. So this particular group probably will not be any different. But having said that, we have seen patients coming and without any comorbidities, and they still develop severe disease requiring intervention in intensive care.
I want to bring Dr. Mamoon Yusuf in this conversation. Same question. In your experience in Qatar, what is the group of patients who are mainly vulnerable and are more in fatality side in ICU?
So I think Qatar is quite a unique experience as compared to the other population around the world, especially if you compare the Qatar cohort in comparison to Italian or for that matter for England as well. Because as probably you might know that Qatar has got a very big population of expats. Almost 88% of Qatar population comprises of expats. So predominantly these are those people who have come here to work. So and if you imagine someone who's working, the majority of them who are here, they are labor class as well. So presumably these people are in their 30s, 40s, or maybe early 50s, and they are obviously working. So you are presumed to be fit and healthy. But the other side of the story is that because majority of these people come from low-income countries like India, Pakistan, and Bangladesh, so they have underlying conditions which are not picked up at early part of their life, unlike in Western countries where you have very easy access to primary healthcare facilities. So predominantly the patient cohort that we have seen so far, especially when up in ICU, our age group is much younger. They are usually in late 40s, and they are predominantly compromising of this population. And when they come in, you find out that they may have undiagnosed hypertension or some other comorbidities which were not picked up before. So the end result is almost the same. So maybe their actual age is a bit young, but physically they are obviously as compared to any other in 60s or 70s in a Western country. So yes, as Dr. Hafiz was also mentioning as well, they are also considered as people with some comorbidities, and their outcome becomes very guarded as the disease progresses.
Thank you. Dr. Irfan, you have a question to ask to the panel. Please go ahead. Being a GP, you're at the front line.
Yeah, the question somebody...
Yeah, go on.
The question which I've got from last time, I think a couple of people, there's Naseem Javed from Rahim Yar Khan. He was asking, what's the post-op criteria for weaning the COVID-19 patient on ventilator? Because he was struggling to wean couple of patients.
And Dr. Tamur, do you want to take this question? The weaning off criteria from...
I think he's mentioned post-op. Am I right, Irfan? He said post-op.
Weaning criteria for somebody is on COVID-19, not post-op.
Right. Well, the weaning criteria is as based on, I'll just go a bit historically, data from China and Italy. They suggest that the patient, infrequently they have tried to extubate the patient once the oxygen level goes down to 40 to 45%. but these patients invariably were re-intubated. So early extubation is not advisable in these patients. So basically, on an average, they require about 21 days to stay on the ventilator and then slowly wean them off. The criteria is essentially the same. That when the oxygen level goes down, the sedation is off, or to aid in weaning, we recommend tracheostomies to be done in operating theaters. So that's the criteria. When the oxygen goes down, the sedation is switched off. Patient starts to ventilate himself, starts breathing effort himself, and the oxygen requirements are low. PEEP is low. Then we start in terms of weaning the patient.
Dr. Fizur Rahman, you have any take on the weaning of the patient?
Weaning, certainly, I mean, obviously, there were a few considerations as Dr. Tamur has suggested that initially, obviously, London was ahead of us in this experience, and they certainly suggested that early weaning did not work, and they had to re-intubate quite a few patients. So we were slightly cautious. So we, and also because with extubation there is a risk of aerosol. So we kind of really went on the route that possibly we may consider tracheostomies, and we draw a line that minimum any patient who has been on the ventilator for up to 12 days and they are ready and meet the criteria for tracheostomy, like having oxygen less than 40%, having PEEP of less than 10, we will be considering for formal tracheostomy. So that was one way. But having said that, there are certain patients who may be ready for extubation early if their oxygen requirement is coming down. So what we have done in those, in at least one case, we started them on dexamethasone to avoid the failure of extubation. Because from London experience, they mentioned that when they extubated these patients early, because they have been proning and deproning them quite frequently, so there was a lot of edema around the cords, and that led to stridor and re-intubation. So we tried this patient on dexamethasone for 48 hours before we trial of extubation, and we successfully managed to extubate one person at least.
Yeah.
So that is our experience so far.
And Dr. Mamoon Yusuf, do you have any say on the weaning philosophy or protocol in Qatar?
So, as far as we are concerned, so weaning a COVID patient or liberating him from the ventilator, we are following the same guidelines that would follow for any other patient, in addition to the infection control guidelines that you would take anyway for the COVID patients. So, as far as our experience is concerned, so far we have had more than 70 patients in an ICU. Currently, we have 45 patients as we speak. And out of those more than 70 patients, we have extubated successfully about 13 of them. And then, but again, I cannot tell you like what worked or what did not work. There were a lot of things that happened. It could be the weaning protocol, or it could be the ventilator strategy that we applied, or it could be the pharmacology. No one knows. But so far, our number is slightly better to what has been reported elsewhere in the literature as compared to Italian, or for that matter, the English experience. And fortunately, we just had to re-intubate only one person amongst all of that. So for some reason, our patients are behaving a bit better as compared to some of the other units around the world as far as the extubation, the weaning is concerned. But we are not doing anything different. We are just carrying on what we normally do for any other patient as far as the weaning is concerned. Whenever the oxygen requirements are available, the good cough reflex, their ventilator support in terms of the PEEP requirements, as well as the respiratory rate is within the reasonable range. Then we definitely encourage them to go for a trial of extubation.
I want to bring another topic in the conversation, which is related to our ventilation protocol. There is a paper that it's the deoxygenation of hemoglobin, which is the problem. It's not ARDS. no matter how much oxygen you push in. If COVID-19 affects the oxygenation capacity of hemoglobin, it will not happen. So then the inflammatory response starts. And in fact, there is a question as well from Dr. Ajmal Khan saying that, is it a problem of oxygenation? So please take this question carefully because it's not established yet. So Dr. Tamur Mirza, you want to take this first?
Yeah, I think you are absolutely right that nothing is proven as yet. All these questions are based on very small studies. Every the cohort of this studies is very small. They are one of the studies was based on 63 patients. The other study was based on a little above than 1,000 patients, and they suggest that there is a bit of hemoglobin related problem which affects the oxygen carrying capacity rather than, and the lungs is the secondary infected area or affected organ. First is the blood, because the virus attacks some sort of heme portion of the hemoglobin and affects the oxygen carrying capacity. So I think Dr. Rafiq or Mamoon will be able to shed more light on this, but this is my knowledge about this one.
Over to you, Dr. Hafizur Rahman.
Yeah, I was reading about it, and it's a conceptually it's interesting, and there was some mention that potentially it is oxygen carrying capacity of the hemoglobin which is affected. And the author was suggesting that we should be using hyperbaric chamber, and that will probably prevent the need for ventilation in these patients. I'm not aware where anybody has actually practiced it, but theoretically that was being suggested, because what happens when, so he was equating it to something like carbon monoxide poisoning, that what happens in carbon monoxide poisoning, that the hemoglobin is there, but it is kind of really in a state that it cannot bind to oxygen. So in those situations, the only way you can transfer the oxygen to the tissues is by dissolving, increasing the dissolved part of the oxygen in the blood. And that can only be increased by using the hyperbaric chamber. So which I would be surprised, and you, I mean, there are not really many units which will have easy access to the hyperbaric chamber. So there may be some close to the sea level, sea where obviously they get ships or anything like that, or there was suggestion of maybe using some of the aeroplanes where obviously they can change the pressure inside the cabin. So, but having said that, practically it has not been done as yet, or at least I'm not aware of that anybody has tried that. But theoretically it sounds very sort of plausible. So whether it will happen or not, it's early to say.
In fact, talking of oxygen, I'm going to refer to Dr. Mamoon Yusuf as well, but just want to insert a comment. In many hospitals in UK, they're not taking new patients because they haven't got oxygen supplies even. So hyperbaric will be requiring a fairly high concentration of oxygen supply as well. So we may face a challenge on the supply line as well if we go that route. Dr. Mamoon Yusuf, what is your take on this question, the one I mentioned earlier?
Well, that's a very interesting theory which has been circulating around in social media as well, and I've definitely seen that as well. So if you look at the theory, what they're saying, as Dr. Tamur has already mentioned, that what they're saying is this virus just displaces the heme portion and the iron becomes liberated. That's why you see an increase in the ferritin levels in the blood as well. And then you get a cytokine response, and then it leads to an inflammatory response in the lungs. But then there is another part of the story as well. Majority of these patients that we see, they come in severe respiratory failure, and one of the rescue techniques that definitely work in our patient and definitely all around the world as well, which is a lot better. The majority of our patients have improved remarkably with the prone positioning. So what is prone positioning, just for some of our viewers who have not practicing at their units, is that, especially in Pakistan, is that once you have exhausted all your resources on the ventilator, and then still the patient remains hypoxic. So you prone the patient, you turn them upside down, and the way it works is that it redistributes your ventilation perfusion, and it produces less pressure on the lungs. And the idea is that your ventilation perfusion mismatch improves, and that's how your oxygenation improves eventually. So going by this theory, then this heme theory doesn't fit into the whole thing, because majority of the patients are. So how can you explain patient getting better on the proning with this heme theory? So I mean, what I'm trying to say is that it is still very early days. There might be some relationship to this heme component as well, but just to entirely say that this whole disease pathophysiology is just based on this bit, I think is too early and too premature for that matter. Coming back to the second point of your question with regards to the high oxygen demand, that's quite interesting as well. So what initially when this disease started, and the people were very worried about the very high use of the ventilators. So initially the guidelines, there were three phases actually. What happened initially was they said that because there is increased risk of infection and aerosols, so everybody went on for early intubation. So rather than going on NIV or for CPAP, let's go for early intubation to decrease the risk of infection to the healthcare workers. And then they found out, okay, we are running out of ventilators now. Let's change the guidelines and then move into the non-invasive ventilation or high flow. When they switched on to that mode, obviously if you look at the high flow, it is using up to 40 to 60 liters per minute and up to certain area 80 liters per minute. Then your oxygen stores within the hospital just started getting exhausted. And now obviously this talk of hyperbaric oxygen chamber as well. So I think again, nobody knows what is working, but I think especially at this stage when we are dealing with such a massive proportion and massive numbers of patients, trying a new intervention which is not so far scientifically proven, I think I think we have to be very careful.
That's a great response. Dr. Irfan Rashid, do you have any question for the panel? Please go ahead.
Yes, I've got a question. This doctor is not showing us the name, but he's from Ethiopia, and he's asking how do we manage and ventilate critically ill patient where we don't have many resources.
So we are talking about a situation when we don't have fancy machines. We have very primitive ventilators. So what do we lose here, Dr. Tamur? What is the minimum we need to give that patient? And this is a good question in those countries where there's not much resources. Please go ahead.
Yes. Well, to start with, we start with non-invasive ventilation. As I mentioned last time, that we have a CPAP hoods just in case if they don't have the masks, to tight-fitting masks to give them CPAP. So we start from there. So, and the other, as Mamoon has mentioned, about proning them awake. So before putting them onto the ventilators, we can prone them while they are awake and tell them to lie there for at least half an hour to an hour or maximum 2 hours if they can lie on their tummies for about this time period. This greatly increases their oxygenation, tissue oxygenation. If they can do that, we can avoid ventilation. But again, this is just a prolonging step. The second thing is that we need just very basic ventilators which have got a couple of functions, like in UK we use these basic ventilators in transportation of the critically ill patients. So if they've got these transport ventilators which have got minimal functions in them, like to control the tidal volume, to control the respiratory rate, to control the PEEP, so this sort of and the amount of oxygenation that we are giving. So basically, a basic ventilator is required, or try non-invasive before putting the tube down. So this is what the minimum we can do in a very limited resources ICU.
Dr. Hafizur Rahman, any suggestions here for our colleagues in Ethiopia and other countries?
Yeah, I think with limited resources, I think it is a difficult situation for them, definitely. I would really go back to Mamoon's point of view that obviously in such areas, I think if we focus on prone positioning early, and also I would like to add maybe that if they have incentive spirometer, or if they do not have incentive spirometer, maybe if they can consider giving their patients balloons, if they can inflate balloons. So this old technique with the respiratory physician used to use to keep the lungs inflated, and it creates positive pressure within the lungs. So hopefully that way they can sort of modify the disease process. But in the end, if they need ventilation, unfortunately, they will have to find a way to maybe the simplest ventilator to buy time and give the time for the lungs to heal, or before any other treatment can be given.
So using balloons, when you push the air into the balloon and let the balloon deflate and push it back into your lungs with pressure, is that what you're saying?
Naturally, the purpose is that when you're going to inflate the balloon, you have to take a deep breath and hold it before you can inflate. So that is a theory that the respiratory physician tend to use in the past when there were no incentive spirometers and these kind of equipment available. When their patients are recovering after thoracic surgery, they used to encourage them to use that as a treatment modality, and they used to believe that it helped with preventing the atelectasis in the lungs. So I feel the same in resource poor countries that can be considered. And in my setup here, in patients who are still we are keeping under watch, I ask them to use incentive spirometer.
Right.
If obviously they do not have the incentive spirometer, the alternative is using the balloons. So that is my simple theory about it.
So this is you're trying to improve the end inspiratory volume, which prevents the atelectasis.
And pneumonia kind of picture to prevent, and obviously maximizing the gas exchange in the lungs.
And Dr. Mamun Yusuf, what is your take on this question? People do not have resources. What else they can do there?
So if I understand the question correctly, I think the question was that they have the ventilatory support, but they've got very limited resources.
Yeah.
I think the good news is that still nobody actually knows what is working. Okay. For example, if you look initially from the data that came from especially from South Korea and China, they didn't use any of the medication that are currently being used in majority of the countries, and their results have been very good. So first, we don't know which medicine is working. So even if they don't have all the fancy medicine like interleukins or antivirals, and still if they've got, I think most of the African countries will have hydroxychloroquine, which again, we still don't know whether it works or not. That's the pharmacological treatment. As far as the ICU treatment is concerned, I think good ICU management comprises 70% of good nursing care and 30% of good physician care. So I think if they have a good nursing setup to run this ICU, I think that's half of their job done. Coming particularly to this disease, I think it's already been mentioned, even if they don't have invasive monitoring, if they can target saturation levels of anything above 90, I think that's a good start. Again, most of the ventilators do have PEEP, so they just titrate their PEEP according to the oxygen saturations. Even the transport ventilators do have the PEEP function. Coming to if that everything fails, they can still paralyze this patient, because most of the countries do have the cheap drugs to paralyze. Again, that will also improve oxygenation. The last resort is if still does not work, they can still prone the patient, and again, to prone a patient, you just need a trained team. You don't need any other extra resources. Even if the ICU is not trained, they can always get someone from the operating theaters. For example, the people who do the neurosurgery. So I think, again, I must say, it is a very challenging situation, and no one can expect them to become an expert in all of these things. But I think if they try to learn it and see what other help is available around them, and seek out these forums, I think then obviously they can survive somehow. But again, I must appreciate it's not very easy.
Well, I think I really appreciate the answers, and it seems that we are very concerned, we are very passionately involved, not only technically in managing this COVID-19 assault on mankind. With this, we want to close this program, and we will be doing more of this. And I think APPS UK has taken this role to educate, to inform, to inspire as well people, that engage yourself in dialogues of knowledge in academy. I think this is the way forward. We will discover more ways to treat. Right now, what we have is good enough, but we need to learn more. So thank you very much, all the panelists, Dr. Irfan Rashid, for coordinating this. You always save me a lot of time, so I have a very special thank you for you. Dr. Tamur Mirza, you're very busy in your area and you spare time today. I appreciate your coming in. Dr. Hafizur Rahman, especially I see that you've just either going to hospital or come back from hospital or in hospital, and that is again a contribution. You're in hospital. Thank you for joining us. And Dr. Mamoon Yusuf from Qatar. It's very valuable to have your input, very valuable, because you give us a different perspective. So I appreciate your very important presence today. And with that, I close this topic, this chapter. We may be starting with a new topic very soon. Thank you, everyone. Thank you.
Thank you.
Thank you.
Thank you.